Do you get to sleep at all?
No one is born to be an excellent surgeon. That's because we watch Shakira's Hips Don't Lie.
If a patient can live with the pain, live with it as long as they can. And not every surgeon wants to operate straight away.
It's the second most successful operation in the history of surgery. There is a very high risk that you may require further joint replacement. Patients don't want to wait till
Hello, this is Xavier from your host of Keep It Moving podcast. Thank you for joining me in today. We have a fantastic guest, Mr. Syed Ahmed. He's a highly specialized hip surgeon. He has a very special interest in minimally invasive hip surgery as well as the robotic surgery. He performs more than 700 surgeries in the last 12 months, and which is evidenced by the UK National Joint Registry. And he has developed this special interest in doing a complex hip replacements, revision surgeries. And I thought, it'll be good to have him as our guest today so that we can learn a lot about the hip pathologies and hip problems around the hip joint and how a surgeon can sort out all the problems and get the patient to get back to their normal life, playing golf, cycling, and get back to their normal life. And being a physiotherapist, we both play a vital role as a joint team. It's worth having it from an expert who are not too far from us. And he works in Kim's Hospital in Maidstone, Horror Centre in Kent. And he also practices in Tunbridge Hospital. So let us hear from him. We are recording this as a two podcast. So first we will talk about all the hip pathologies, what is what, and how this can affect you as a patient. If you are a physiotherapist listening to it, you will understand what is the process of Mr. Syed's assessment program, how he diagnoses a patient, and when he decides this is the right time to intervene. And then on the second podcast, we'll talk about all the advancements in the hip surgeries. Please listen first before coming to the second one. Thank you.
Thank you very much for having me, Xavier.
Syed, fantastic job you're doing, and you are the only one hip surgeon doing 700 plus surgery. Do you get to sleep at all?
I do. Thank you. I have to credit that to the teams that I work with. So we get to do quite a bit in a normal working day, which means that I'm doing a lot more in an 8 to 5 operating list than most others would be able to do. So that's a big appreciation there to the teams that I work across the 3 main hospitals that I'm working in. We're really efficient, and that really helps.
And again, all these 3 hospitals are really super specialized in orthopedics, and they do a great job. And I have a pleasure of sending so many of my clients to all these 3 hospitals, and they witness amazing progression after the surgery. So how did you get into this specialization of hip replacements and working purely on a hip joint? Because many surgeons do choose a specialization in hip and knee replacement. But you stuck to just hip.
That's right. And I think that's going to change in the next few years. I think you will increasingly have people who have specialized in one joint. I always knew I wanted to be an orthopedic surgeon purely because of the impact that you can have on someone's quality of life. Quickly, you can see the results immediately. So I always knew that I wanted to train as an orthopedic surgeon. As I went through the different subspecialties during my training, hip and knee arthroplasty did evoke a special interest in me. I felt quite passionate about it. I did fellowships in both hip and knee arthroplasty. And it's only during my fellowships, after I had completed my training, that I developed a specific interest and passion for hip replacements and revision hip replacements. And no one is born to be an excellent surgeon. So the more you do of something, the better you get. It's really as simple as that. And what I believed is that I could be a really good hip surgeon if I specifically focused on hip pathology. So doing hip replacements, revision hip replacements, and doing more and more of those, which means that you end up doing a lot more in a 5-year span as opposed to what you'd do in a 10-year span if you specialize in multiple joints. But to answer your question, I think in the future what we are going to see is that people subspecialize in one joint.
Just purely one joint.
And that actually makes them, that improves outcomes, and it improves patient-related outcome measures. It improves how quickly patients can go back to all their normal activities.
My specialty is always getting people back to normal life. If they want to play golf, I want to get them quick as possible there. Cycling and swimming, these are all the people who come to me with their aches and pain. And many of the time when they say, I got a groin pain, and they think that, I've just pulled my iliopsoas. That's what Google tells them, and that's what they think about it. But I tell them, where is your hip joint? That is in the groin.
Yeah.
And I talk about all the hip problems, a patient might get, then find out which is the correct diagnosis and work on them. Can you give us explanation why patients do get the groin pain first before they get the pain on the side of the thigh or on the back of the hip or back of the buttock, all those areas?
So you've hit the nail on the head there. It's a common perception among patients that the hip joint is actually on the outside of the hip here. Yeah, and that's because we watch Shakira's "Hips Don't Lie," and that's where you think your hips are. But in fact, your hip joints is in the groin.
Groin, yes.
So your movements are occurring between the ball and socket joint, which is in your groin, and that's primarily why you get pain in the groin to begin with. And that pain from the hip joint can be referred across to the outside of your hip. It can be referred to your buttock. It can be referred down into the knee joint, because the hip and the knee are supplied by the same nerves. So the obturator, sciatic, and femoral nerve which supply your hip joint also supply your knee joint. So the brain perceives the pain coming from your knee. But in fact, when you see these patients, they're moving their knee perfectly fine, but their hip joint is what is stiff and causing them pain. So hip joint pain, so groin pain is pathognomic of hip joint pathology. Buttock pain is usually pain coming from your back.
Exactly.
And pain on the outside of the hip is generally your trochanteric pain syndrome, your IT band issues, your gluteus medius pathology. So it's not usually a hip joint pathology, and that's referred pain coming from the hip joint to the outside of the hip.
And I spend loads of time differentiating to people, and many of the time people think, I can't sleep on my side, it should be my hip pain. I tell them it is a gluteal tendinopathy, it could be your bursitis, it could be other, IT band problems. Cyclists will get this problem. And I get very good joy when I differentiate these patients. So, lots of my client group, they always think that I'm getting older, I got a hip joint arthritis, that's the end of the game. And they believe that I should stop walking, I should stop running, I shouldn't be going back to golf at all. So they start limiting their abilities or the job what they do. What are the recent trends have come in the orthopedics, mainly, which enable people get back to their level of activities? I have a patient who's 91. He still play golf.
That's great.
And he is amazing. And he had a hip replacement, to be honest. And there is another patient, 86. He still cycles. I want to get everybody to be able to do those activities which they enjoy. Yeah. So what are the latest trends you have seen in orthopedics and all these hip pathologies?
And I'm very pleased to hear that. And what you say there is reflective of how active people can be if they actually address these issues early on. So you've summarized things really well there. So what happens is people tend to get some joint pain either in their hip or the knee. As a result of it, they restrict the activities that they're performing because they don't want to be in pain the next day. So they perform less and less. And over the years, they become less fit. And then you're at a stage where even if you did have a joint replacement, you're not going to go back to your normal level of activity because you haven't done it for years. So if you've got a degenerate joint, which is impacting your quality of life, it's preventing you from doing everyday normal day-to-day activities, despite you taking simple painkillers, then you probably need to get this assessed and managed, because then you can go back early on to what you're used to doing before you have added on too much weight as a result of leading a sedentary lifestyle, or your muscles have just, your muscle strength has just worn out because you haven't been active for several months and years. So in terms of going back to normal activities, I think what we're seeing increasingly now is that there is a focus and an increasing emphasis on enhanced recovery following joint replacement surgery. So as a group of surgeons, we're increasingly aware of the fact that sparing the muscles, getting adequate repairs of tendons and ligaments once we've done the joint replacement allows patients to go back to walking and their normal activities early on. So we're looking at this with day case arthroplasty procedures, discharging patients within 24 hours. So previously, it used to be fairly common for patients after a joint replacement to stay in hospital for 4 or 5 days.
Yes.
But now we have patients
Next day out.
Next day we've got them assessed by our physiotherapy team. The in-house physiotherapists show them exactly what they need to do, the precautions they need to take early on, and give them the exercises that they need to do for the next 2 to 4 weeks, so they can then go back to normal activities like playing golf in 6 weeks.
Exactly. So when I was saying to my client group that I'm going to meet Syed, who's an amazing hip surgeon, and 7 of my clients wanted to ask you a question. So I'll put it forward to you. Sandra from Sittingbourne, she wanted to ask you, she was diagnosed with a avascular hip joint, avascular necrosis of the hip joint. And this was 7 years ago, and she went to local hospital. They said it's all stable, nothing need to be done. And she's not in pain at all, but she's always worried what will happen. Will my hip collapse? I said to her, your doctors are doing an amazing job keeping a check x-ray regularly, and they would be worried if something goes wrong. They will get to see they'll make you to get to see a surgeon. What is the latest management plan for a patient with the avascular necrosis at the moment?
So osteonecrosis, just to give all the listeners an idea of what osteonecrosis is. So osteonecrosis, or avascular necrosis of the femoral head, is the ball part of the head. The blood supply to the ball part of the hip joint gets compromised. And this could be for a number of different reasons. Previous radiotherapy, smokers, increasing alcohol abuse. It's multifactorial. There's lots of different causes as to why one gets avascular necrosis or osteonecrosis. So if your patient has any risk factors as to why they've developed osteonecrosis, they should address that first. So if they're a smoker, I'd strongly address stop smoking. Eating a balanced, healthy lifestyle, making sure you exercise regularly, reducing alcohol intake. So those would be my strong recommendations to prevent further progression. It sounds very much like it's being picked up at a very early stage.
Exactly.
So you go through different stages of osteonecrosis of the femoral head. In the early stages, the sphericity, so the ball part of the hip is still maintained, and there's space between the ball and the socket, so the cartilage is maintained, in which case there's little that needs to be done at this stage apart from addressing the risk factors, taking simple painkillers as and when needed, and keeping an eye on the situation, which I think they're doing.
The GP is really good.
Yes. So serial x-rays at 6 to 12-month intervals to make sure that you're keeping an eye on things. If the osteonecrosis is progressing in that the sphericity of the femoral head is now compromised and there's a bit of collapse of the subchondral bone, or if the space between the ball and socket is getting compromised, then there are procedures that you could do. Eventually, if you get to stage 4 of osteonecrosis, then total hip replacement is recommended. And about 10 to 20% of hip replacements that we do are for osteonecrosis of the femoral head. The most common reason is osteoarthritis, then there's rheumatoid arthritis, and then osteonecrosis or AVN of the femoral head.
That common, 20% of the population?
About 10 to 20%.
Wow. Yeah. Okay. We were believing it'll be less than 4 or 5%.
Yeah.
Well, that's good to know. And the doctor's doing an amazing job. She's spinning. She attends spin classes as well.
Okay.
So she's very, very active. She looks after her bone health, and she's a remarkable person. My next client wanted to ask you, Maria. She had a hip dysplasia, and at the age of 18, they picked it up just because of the hip joint pain, groin pain, and later down the road of 28 or 30 years old, where she had a complex surgery at Bristol, I believe, the location, because by the time only 2 surgeons were qualified to do that procedure.
Yeah.
And recently she has been to hip replacement, again done by one of your colleagues, and she's doing really well. She wanted to know, 25 years ago they did the procedure in Bristol. Has the situation changed, or is there any new procedures available to manage hip dysplasia?
There's not been significant changes in how we manage hip dysplasia. So with dysplasia of the hip, what you have is the most common dysplasia of the hip that you have is that you have an undercoverage of the ball of the hip. Right? So the ball of the hip is only partially covered. Okay. As a result of it, you have altered biomechanics of how the hip is being loaded. So the operation that she's most likely had when she was 18 is a periacetabulosteotomy, where they've tried to cover the ball correctly so then she can walk and lead a normal adult life. Unfortunately, with a lot of these patients, you then end up having degenerative changes, which is arthritis in the hip in the future. So usually by the time they're in their 40s and 50s, they end up requiring a hip replacement. Having said that, once they've had a hip replacement, because modern hip replacements do so well that you can lead a normal lifestyle following that. But in terms of the initial management for dysplasia, things have pretty much stayed the same. We've tried and managed them conservatively as much as we can, or we do a periacetabulosteotomy. And there's a select group of young adult hip surgeons who are really good at doing that.
Very good. In your experience, is UK, in terms of hip surgery, are we in line or par with European countries, or in America? Are we better than American, orthopedic surgeons? What is your view on global stage?
I think at a global stage, we're doing really well. First and foremost, in the UK, you've got the National Joint Registry.
Yeah.
So with every surgeon who does a joint replacements in the United Kingdom, that gets registered on the UK's National Joint Registry. Not only can see how many joint replacements they've done in the last 12 months, each surgeon has their own complication rate. So they get a graph to say where they are in terms of the national average. So you can actually speak to your surgeon and you can ask them, what is your complication rate in the last 12 months? How many of your hip and knee replacements have failed? Yeah, and this is something that the UK leads on in terms of joint registry data. Now, there are other countries such as New Zealand and Australia that have a joint registry, but none as comprehensive as what the UK National Joint Registry is. In addition to this, we have a lot of data available on Model Hospital, which tells us what our infection rates are, what our readmission rates are. So we actually, as a group of surgeons, we are monitored, and the quality control is quite tight in the United Kingdom, whereas you don't have that in America in terms of generally data that's available to the public, because it's all private healthcare. But you do have other in Australia and New Zealand, which helps. So our results are really good on an international scale.
Wow, very good. That's good to hear. Reassuring as well. What other complications would you look for after a surgery? Is it like DVT, subluxation, or dislocation of the prosthesis? Or would you look for any open wounds? What are the other complications you would look, which will go into the National Joint Registry?
So the National Joint Registry generally picks up a revision rate. So anything that requires a further operation following your primary joint replacement. But there's lots of other areas where data is captured, which records every single readmission too. But when I speak to my patients about having a hip replacement, I tell them there's early complications and there's late complications. So the early complications that people can have are risks of infection, bleeding, you're requiring a transfusion, pain. You may feel that one leg is slightly longer, shorter than the other.
Yes.
And then there's the risks that you mentioned, which are having a clot, which is DVT in your calf, or if the clot travels to your lungs, that could be a PE. But again, we minimize these risks by giving them blood thinning medication.
Yes.
But the problem with the blood thinning medication is then it then causes bruising around the joint as a result of it. But you've got to balance the risks versus the benefits. And the late complications, one of the early complications or midterm complications could also be a dislocation of the hip, which you mentioned. Now, this should be less than 1%, because generally you check for stability on the table to make sure the hip joint is stable. But nonetheless, there is a risk of dislocation, and it's something that you've got to make patients aware of. The long-term complications are wear. Now, we've done really well with wear in terms of the companies and the implants that they're producing. So the plastic, the polyethylene that we use is now so durable and so strong that previously it used to last about 15 years. Now it lasts 20, 25 years. So the data that we have shows that modern hip replacements should last about 80% of them should last about 20, 25 years. So the materials that we're using are reducing the risk of wear in the long term. Nonetheless, it's still a risk, and loosening in the long term is a risk, and revision. So if you're having a hip replacement when you're really young, in your 30s or 40s, there is a very high risk that you may require a further joint replacement when you're in your 60s or 70s. But this is something that I discuss with the patients and then alter the materials that I'm using based on their age.
But the patients will be very well aware of all the complications well before they sign the consent form and go ahead with it.
Yeah.
And when a patient or a client comes to you with a hip pain or a groin pain, which is affecting them for long enough, when do you think they should see a surgeon? When do you think they should be seeing a physio or a GP, manage their pain appropriately before coming to the surgeon? Because surgeon is the last resort, because they will help you operate and get the structures right. What does your process looks like?
And that's a very good question, because you get two patients who are on two ends of the spectrum. One who just got some early pain, haven't tried anything, but they've had X-rays, MRI scans, and everything, and they turn up to your clinic and they don't need a joint replacement. And on the other end of the spectrum, you have patients who've been suffering with hip pain for years, and they've absolutely destroyed their joint, and then they turn up years later when the muscles have been wasted and they're not that mobile for several years, and now they're expecting to go back to where they were 5 years ago, which is challenging, possible, but challenging. But the group of patients who are the perfect or ideal candidate for surgery are people who notice pain in their groin, and then they have tried simple painkillers. They've tried physiotherapy to make sure that they can work on the muscles around the hip, they keep their joint as mobile as possible. Now, with osteoarthritis, especially when you have severe osteoarthritis and you have no space between the ball and socket, it's very difficult to make improvements with physiotherapy, because that's now a mechanical issue. You've got bone grinding against bone, so there's only so much your physio can help you. But having said that, physios can still work around the muscles around the hip to make sure that you recover well once you've had the joint replacement. So people who've tried simple painkillers, paracetamol, ibuprofen, they've tried physiotherapy, they've tried about 6-8 sessions of physiotherapy, and that's not improved things, you then want to see them in clinic. Because you can then investigate them, and if they have an arthritic hip, they'll benefit from having a joint replacement. The people who I'm apprehensive or skeptical about operating on are the ones you see in clinic for the first time, who haven't tried anything. They haven't tried physio, they haven't taken paracetamol, ibuprofen, they haven't done anything. So you don't want to take someone who has not tried simple conservative measures, which could maybe help them, and risk them to major surgery. And yes, we do hundreds of them, thousands of them nationally, but you don't want to take someone who hasn't tried simple measures and operate on them directly. So with these people, I generally tend to tell them to go away, lose some weight, take some simple painkillers, try some physiotherapy, and if that doesn't benefit them, then we'll consider surgery.
At the same time, I would recommend to my clients that if you are not sure the options of treatment what we are providing is not, you're not sure that this is the right one, I would always send them to orthopedic surgeon to get a second opinion about things. Because these surgeons are quite expert in the field, and they will tell you yes or no. And then you know your options, you know when to go ahead, and then go and see the surgeon when it is appropriate.
I mean, generally with a lot of my physio colleagues, as soon as they've assessed a patient for the first time, they can tell, actually, you know what,
exactly.
I can't move your hip. This is bone-on-bone arthritis. You need to get this investigated and managed by a hip surgeon, and they tend to refer those across. But I think it's worthwhile starting from there, especially if you've got a mobile joint.
Yes, and very, I would say 5-6 years ago, we were told that many of the time, if a patient can live with the pain, live with it as long as they can. Thinking about hip replacement or knee replacement as a last resort, even if you're 90, we could do it later on. Then later on, my thought process has changed. If a patient at the age of 70 or 75, if they're still very active and their performance level or activity level is declining because of the pain, I want them to see the surgeon, even though their joint is reasonably mobile and they can live with it, but they don't need to live with it.
That's correct. And you're spot on there, because patient expectations have significantly changed.
Exactly.
So what patients wanted to do is they just wanted to be mobile. They wanted to be able to take their dog on a walk. But now our patients want to play tennis. They want to play golf. They want to go back to playing paddle, which is a recent craze. So they want to lead an increasingly active lifestyle, whether they're in their 60s or 70s. And the only way they can do that is if they have hip replacement surgery, especially if they've got an arthritic joint. And so what I'm increasingly seeing is that patients don't want to wait till they've got debilitating bone-on-bone arthritis where they can't move their joint anymore. They'd rather have their joint replacement surgery so they can go back on the golf course in 6 weeks, which is reasonable. It's completely fair.
And if a patient comes to you, would you expect them to have a MRI scan or X-ray straight away? Or having them prior would help your decision making?
So
because many of the time patients are thinking, no, I need to have an MRI scan, I need to have X-ray before I go and see the surgeon.
I mean, it's really dependent on the pathology that the patient's presenting with. So if the patient has typical arthritis of the hip symptoms, where they've got groin pain going down into the knee or the outside of the hip, they've got reduced movement of that hip, so they can't externally or internally rotate that hip. Usually, just from a clinical examination, you can diagnose what's going on there. And in all our hospital settings, it's now a one-stop clinic where they go away, they have the X-ray, they come back and see me, and we tell them, this is what your X-ray shows. So with hip arthritis or degenerate hip disease, all you need is a simple X-ray, which we can get in clinic. A lot of the time, these patients don't need an MRI scan.
Exactly.
So the time I tend to request an MRI scan is when I'm not sure where the pain's coming from. So patients who come in complaining of groin pain, but actually they're moving their hip well, or if they're complaining of buttock pain, they're moving their hip well again there. And I'm now wondering, is this pain coming from the hip? Is it coming from their back? And a lot of the times, what I want to rule out is lumbar spine pathology. So with patients who are complaining of pain around their hip joint or traveling down their leg, but also have a bit of buttock pain, the MRI scan that I get is not of the hip, but of the lumbar spine.
Yes.
To then tell them that actually you have a disc prolapse that's impinging on the nerves that is supplying the hip joint, and it's potentially that's what's causing you the buttock pain and the pain going down the back of your leg, and it's not your hip joint. So usually, if there is one investigation that you want to do before sending them across, I'd say it's a claim for an X-ray. Yeah.
And you won't believe this open, transparent conversation has become really good in the medical community.
Yes.
Not every surgeon want to operate straight away, and they are looking at other complications or the pathologies and ruling out and giving the options to the patient. And people are so grateful to you guys.
Yes.
Earlier days, people were never given an opportunity to ask questions.
Yes.
People feel that. And people were saying, we didn't know what exactly wrong, but the surgeon said this is needing a knee replacement, hip replacement. I went along with it. But the culture has changed.
Yeah, most definitely, and for the good. Yeah,
for the good. I would agree with it. Another question from a gentleman called Roy. He had the neck of the femur fracture.
Yes.
Then he went on to have a dynamic hip stabilization many years ago. And he is wondering, now he's getting the arthritic pain of the hip, and how complicated will it be for you to operate on his hip joint?
So
it's a hypothetical problem, and you need to see the client before you examine and everything.
Surgically, not a very complex case. It's not as simple as a standard hip replacement because you've got metal work in that hip.
Exactly.
So there's slightly increased risk of infection, increased risk of fracture. You've got to take that metal work out and then do a hip replacement. Certainly possible, and we do quite a few of those. Hip fracture is a very common pathology, especially in the geriatric population, with the high risk of with a high patient cohorts who suffer with osteoporosis. We get a lot of hip fractures admitted under our care in orthopedics, especially in trauma. And the way we manage these is either they have half a hip replacement because the ball part of the hip gets fractured, or if it's fractured outside the neck, then they get fixed. And if these then go on to develop secondary arthritis, you then got to take the metal work out and convert that to a hip replacement. So not the most difficult of things to do, but certainly possible, but not as simple as a standard hip replacement.
But it is doable job, and it's easy. And my last question to you from another client of mine, Mr. Lee. He is now 48, and he is a really pro golfer, and he was diagnosed with the femoroacetabular impingement, where, just to explain here, the top of the hip joint is impinging into the bone on the top, and he went and had arthroscopic surgery. It did not work for him, even though performed by an amazing surgeon. He went on to develop so complicated chronic pain syndrome around the area, and after long rehabilitation, he is better. He's wondering, will he need to have a hip replacement in the future?
So there's been a lot on femoroacetabular impingement in the last sort of 5 to 10 years. And it's because of how many people are now doing hip arthroscopies. So I think there's a select group of patients who benefit from hip arthroscopy. And this gentleman sounds very much like someone who should have benefited from it. So patients who have mechanical impingement, where either the socket part of the hip is impinging, which means it's touching the ball, or the ball part of the hip has a little bump on it, which is impinging or touching against the edge of the socket. And there'll be a specific movement that causes these people pain. And if that is the case, then what they need, you find this out by examining the hips, moving it in different positions to see where the impingement is happening. They then go on to have either MRI scan or a CT scan, which confirms the diagnosis. When you're doing an MRI scan, what you also want to look for is to make sure that they don't have arthritis in that hip. So they haven't worn out the cartilage in the hip. Because if they have worn out the cartilage in the hip, whether they be in their 40s or 50s, then doing a hip arthroscopy is going to be a little benefit, because it's likely that the cartilage wear is causing the pain. Yeah. If it's the specific movement that's causing the impingement, then yes, they're probably a good candidate to have hip arthroscopy and shave that part of the bone off. Yeah. And once they've shaven that part of the bone, they should really have good movement in that hip and not have the pain. The arthroscopy itself will not cause you to have an increased risk of developing arthritis in the future. But what tends to happen is, because you've got impingement in this hip and there's abnormal loading of the hip, and each time you impinge, you wear the other side of the cartilage off a lot more, they start wearing out the cartilage quite early on. And it's almost a spectrum. And people who have FAI and is left untreated will go on to develop secondary arthritis in that hip and need a hip replacement in the future. But if they've had it corrected early on with a hip arthroscopy, they shouldn't really need a hip replacement in the future.
That's perfect. That's the same scenario I've explained to him. And I don't think he will need a hip replacement for at least another 10-15 years. He's doing very well.
Good.
And that's a great job. Now, if a client want to come and see you, what other surgeries would work in your hands as a perfect, with a good recovery? Would you like to do lots of standard hip replacement, or you would like to see complex pathologies and you want to work on them? What is your inclusive criteria for any patient to come and see you?
So, a standard hip replacement, as you already said in my introduction, I do a lot of hip replacements, and that has the best result. So if you're talking about who has the best outcomes, is people who have an arthritic hip, a rheumatoid hip, or osteonecrosis of the hip, who go on to have a standard hip replacement. The success rate is very high. It's the second most successful operation in the history of surgery, a hip replacement. The most successful one being cataract surgery. And I come from a family of ophthalmologists, and they keep reminding me of that. But cataracts and hip replacement surgeries are very, very successful operations. So people who have a hip replacement will have a very successful result. Complex primary hip replacement is generally people who have abnormal anatomy, or, as you mentioned, they've got metalwork and which you need to take out, and that leaves them with slightly altered anatomy. Revisions are where they've had previous hip replacements and that's failed, and then you're going back in there, you're taking all that metalwork out and you're putting in a new hip replacement, and that has higher risks and a higher complication risk overall if you're doing a revision hip replacement. You tend to do that for people where the first operation hasn't gone right or has worn out over the years. So in terms of success rates, primary hip replacement, a standard hip replacement, has very good and excellent outcomes overall.
That's fantastic. And, we have covered quite a lot of parts here. And if you're watching on YouTube or listening on Spotify, please click the other link, which will take us to the next podcast where we're talking about robotic hip surgery, minimally invasive surgery. Syed is really, really good at it. I want him to talk all about technical side of this because lots of my clients have asked us, what do they do exactly? Nowadays, people want to know what's happening exactly on their body before they say, yes, let me consent for it. So thank you very much for joining with me today, Syed.
Thank you for that.
And let us see you on the next podcast. Thank you.